My initial interest in TCAR is related to the long history we've had with doing transfemoral carotid artery stenting. And there's certainly a subset of patients that are at high risk for endarterectomy, but I was never totally happy with transfemoral carotid artery stenting or transfemoral CAS because there's hurdles that you have to overcome, such as manipulating the aortic arch and then crossing the lesion before you have embolic protection. And those were things that dissatisfied me. And the appeal of TCAR is that we were able to access the carotid artery without manipulating the arch, and that we did have embolic protection before crossing the lesion, which for me has tremendous appeal, in that you can be much more aggressive about how you approach the lesion, cross it, and treat it without worrying about generating emboli prior to the embolic protection. Initially, early on, like with any procedure, we were somewhat conservative with the patients we would offer it to. And by and large, it was, I would say 80% of the patients we would do transfemoral CAS on, we converted to doing TCAR. As time went by, we became more comfortable with it, and we saw that the outcomes were good. We started to broaden the patients that we would treat. So initially it was high carotid lesions, patients with redo neck surgery, or patients who had immobile necks from previous like cervical fixation. But as time has gone by and as we've become more comfortable, I would say at this point in time we're about 40% TCAR and about 60% carotid endarterectomy in our practice. The patient experience is somewhat interesting because as surgeons, we have patients who come back from carotid endarterectomy, and occasionally we'll have patients who are unhappy with the neck incision in the scar that they wind up with. And certainly there are opportunities to do minimally invasive carotid endarterectomy with small incisions, but by and large, the incision tends to be much larger than a TCAR incision. And also the placement of the incision with TCAR being just above the collarbone seems like it's less obvious. And my impression is that even at 1 month and 6 months and out to a year, I still have patients who are not happy with their neck incision from endarterectomy. And it's something you really appreciate once you start doing TCAR and you realize that you don't hear as many complaints from those patients. Otherwise, the patients typically are similar to endarterectomy patients in that post-operatively there's not a lot of issues with the wound. They all heal quite nicely. And their length of stay, if anything, is a little shorter than the average endarterectomy patient. The recent decision by the FDA to include or allow TCAR to be used in standard risk surgical patients is very interesting and appealing. The long-term outcomes for carotid stenting with regards to long-term stroke and long-term restenosis is very similar between carotid stenting and endarterectomy. And you really, for transfemoral CAS, you pay the price up front in symptomatic patients in that the periprocedural stroke rate is higher. Well, with TCAR, it appears as though the periprocedural stroke rate and death is similar to endarterectomy. And so I think for many standard risk patients now, TCAR will hold a lot of appeal. And I think it will be something that will certainly be used increasingly in patients, particularly in the 60 and 70-year-olds, where endarterectomy has certainly been a long-standing and very effective procedure. I will say that for surgeons who are thinking about whether they want to get involved with TCAR, that with any new procedure, I think you have to be a little bit patient and be willing to put in the effort, but the outcomes of the procedure are quite good. The intraoperatively, the procedure takes, at least takes me about half the time it takes to do a normal endarterectomy. It's around 45 minutes to do the TCAR procedure, and in my hands, it's almost 2 hours for a standard endarterectomy. So there's a lot of appeal to, to the TCAR procedure, and I think that, going forward, I expect the procedure to become relatively widespread. The learning curve for TCAR, I think, is relatively short. And this includes not only surgeons who've done transfemoral CAS in the past, but also surgeons who have no experience with carotid stenting, but the procedure itself I think lends itself to being quite safe with the embolic protection. So even surgeons who've not done a lot of transfemoral casts can effectively do this procedure. The future for TCAR is promising. The standard patients that we take care of, the methodology with how the procedure is done and certain techniques that we like to do while doing TCAR, they seem well established. The patient populations that we need to be able to address in the future are those with low carotid lesions, which are close to the clavicle, and also heavily calcified carotid lesions. And these are areas where further study and new potential treatment options need to be developed.